We are still with you today for this PHA in Your Child Q&A with Dr. Eric Austin. This event today is here to provide, a forum to discuss the ways that pH affects children and answer all your questions. Welcome, Dr. Austin. Thanks for joining us.
Thank you.
So first of all, I'm going to introduce Dr. Eric Austin. He is a physician scientist and an educator. He is a pediatric pulmonologist specializing in pediatric pulmonary medicine at Vanderbilt University in Tennessee. So with that being said, want to get right into things. I know our time is limited. Can you, talk to us about this? Let's do some level setting questions. What is pulmonary hypertension?
Yeah, great. So pulmonary thanks for having me, by the way, Jill.
Oh, no, thank you so much.
No worries on the technical. But as I was saying earlier, we all can be a little more understanding these days with all this stuff. So I'm honored to be a part. PHA is such an important part of the pH experience for children and adults. And so pH, or pulmonary hypertension, is really a condition in which you have elevated blood pressure in the lung circulation at its core. Just like your grandma may have hypertension for 50 years and you measure it in her arms or her legs, we're talking about pressures in the lungs. So the lung blood vessels have high pressure, different from the arms and the legs. And that pressure elevation has certain criteria that we have to meet to call it pulmonary hypertension. And we measure that technically by heart catheterization or cardiac catheterization. So at its core, pulmonary hypertension is high blood pressure in the lung circulation. And then there's a bunch of different causes of pulmonary hypertension. And each of those kind of help us put people into boxes to think about what an individual, or in this case, a child's pulmonary hypertension might be. We have what we call pulmonary arterial hypertension, which is technically the first group of diseases that fall under the pulmonary hypertension umbrella. And pulmonary arterial hypertension is actually characterized by a disease that is really largely of the blood vessels themselves in the lung. So this can happen for a variety of reasons, but inherently the pulmonary vasculature, the pulmonary blood vessels are hypertensive, and it's not due to a lot of other extrinsic factors to the best we can tell. And I'll talk about what that means in a second. And there's a bunch of subcauses of pulmonary arterial hypertension, as you well know. So that you can be genetically inherited, so heritable or even familial pulmonary arterial hypertension that comes because there's a genetic variation that a person inherits that we either know what it is or we haven't figured out what that variation is yet, or mutation. There's idiopathic, and that's basically the same thing as heritable or familial, but we have no idea why the person gets it. There's no family history. They just develop it for reasons that are not entirely clear. You can develop it because of heart disease. So some people who've had a congenital heart disease that they're born with that either is repaired or not repaired can cause PAH, or pulmonary arterial hypertension. Portopulmonary, which I know is something that the PHA has been working on lately. Liver-associated dysfunction can cause pulmonary arterial hypertension. There's an interesting communication between the liver and the lung that we don't totally understand. You can also see it associated more commonly in adults, but you can also see it in children who have autoimmune or connective tissue diseases. So, for example, you may have heard of scleroderma or lupus, mixed connective tissue disease. Those are thankfully not as common in children, but we see a lot in the adult patients. And then you can have PAH due to a wide variety of other causes, including AIDS or HIV. Thankfully, HIV is so well controlled these days in the North America area that we don't see a lot of HIV-associated PH. So that's group one. That's a basket. Group two is caused by, really, it's a plumbing problem in essence. It's people who have left side of their heart is dysfunctional. So when you think of the lung vasculature and the lung blood vessels, the blood returns from the body, comes to the heart, and it comes to the right side of a person's heart. It goes from their right atrium into their right ventricle, and then it's pushed into the lungs, and that's where pulmonary hypertension is, in the lung blood vessels. That blood returns with oxygen to the left side of the heart, where it comes into the left atrium and the left ventricle, and then it's pushed out to the body. So if you have a left-sided heart problem, essentially you have a backup of blood flow that's not as good as it ought to be. It doesn't flow as well as it should. So people have left heart disease, and most commonly that's not children. That's actually adults who have heart disease associated with blood vessels, like you may have heard of coronary heart disease or heart failure traditionally in adults. That actually can cause a backup of plumbing, and that can cause pulmonary hypertension. That's a less common cause for most children because a lot of children don't have left-sided heart disease. The third cause, group 3 pH, or high blood pressure in the lung circulation, is actually due to chronic irregular levels of oxygen delivered to the lungs. So you can see that in the adults population. We see that in people who have what's called COPD, or you may think of like smoking associated lung disease as the most common. In children, we see it for former premature lung disease. We see it from developmental lung diseases that occur because something happened either before or after delivery that caused some insult to the lung, like Down syndrome, congenital diaphragmatic hernia. Those would be two common things, or other syndromic conditions in which the lungs don't form as well. Group 4 is less common, but really important to understand, and that's chronic thromboembolic pulmonary hypertension, or chronic clots that either continually manifest or they happen and we can't clear them. They can cause blood pressure elevation in the lungs. And those are the 4 big categories. I'll hush up now, but I wanted to give that broad overview.
Well, I appreciate explaining the difference. Out of those categories, the different groups you're explaining, is there a difference between the way they affect adults and children?
Yeah, that's a good question. So not really, honestly. The adult and the pediatric experience with pH is relatively similar in terms of the impact, because at its core, what's happening is there's high blood pressure in the lung blood vessels that the heart is not used to pushing against. And normally the lung blood vessel pressure is about 5-fold lower than the body. And so that right side of the heart that pushes blood through the lungs, it's not used to being the workhorse that the left side is. So that's why I alluded to before, your grandma can have high blood pressure for 55 years. She dies when she's 94 in her sleep and thankfully has a great long life. No one really thinks about her silent blood pressure. She just takes pills for it. In both adults and children, the right heart's not as strong or as powerfully used to pushing against pressure as the left side of the heart. So in both children and adults, there's a threat that over time, high blood pressure in the lung circulation can impact the right heart more quickly and cause right heart failure. What we do see a little more commonly in children, because they probably are more active and they push themselves a little bit more, is they'll have pass out events or other things that could cause them to drop suddenly. That happens in children and adults, but it does seem to perhaps be a little more common in children, probably because adults, we're just lazier species than children. We don't push ourselves anymore. We're at desks like I am right now, working.
So with that being said, can you explain how living with pH affects every child differently?
Yeah, absolutely. It's a great point. So I mentioned to you that pH is really an umbrella term for those 4 subtypes, and there's a 5th that's kind of a wastebasket of other types that I didn't mention. But it affects children dramatically differently. In large part, that's because those 5 types and the 4 I talked about have different impacts on children. So that group 1, or PAH, is really a rather chronic, unremitting disease that is really not something that you see children outgrow, in rare exceptions. And so that becomes a part of who they are from the time of diagnosis onward. And it often progresses and can get a little bit worse with each passing year. And by worse, I mean the pressure may not change, but the strain on the heart can be progressive and difficult. Someone just put in the chat box, I didn't mention to it, but there's another term called PPHN, or persistent pulmonary hypertension in the newborn. That technically is part of the group 1 experience, but it's very different. That's actually a transient pulmonary hypertension that occurs following delivery, where a child doesn't adapt to the being within the mother's womb and then moving out into the world quickly enough. The blood pressure stays high for 30 days or so and then gets better. So that's a form of pH and PAH actually that gets better, whereas most PAH forms don't get better. In contrast, for example, a person who has premature associated lung disease, well, that premature associated lung disease, it probably never completely heals, but their lungs grow and develop and they become larger. And if you can give nutrition to those people, let them feed and grow, avoid lung insults, many of them outgrow their pH, at least to an impactful point in their lives. Individuals who have Down syndrome or other syndromic irregularities that are different from the population, they sometimes can be even very different within that described syndrome. Some of them are impacted by virtually nothing and do wonderfully. Some are very impacted by interval flu or viral exposures and other things. And so the clinical course for an individual who has the term pH is very different across the spectrum, largely with group 1 PAH being a more chronic unremitting challenge, whereas group 3, which is the other most common cause of pH in children, being a little bit more likely to potentially outgrow and or stay tolerable. Group 4, I didn't mention, but it's really the only truly curable type of pH if you can remove the clot and prevent further clotting and control the pressure.
So with all that being said, and I do appreciate you addressing persistent pulmonary hypertension in the newborn, can you explain the differences in treatments between, oral Medicaid, like what gets treated with what, or what can be done for obviously these very different cases for different children? What's the course of treatment?
Yeah, thanks for asking that. So the first thing, and the people who work with us at Vanderbilt know really well, that we try and do is, first of all, make sure we have the right diagnosis, of course. And so there's certain diagnostic criteria and algorithms we go down that are kind of accepted across both pediatric and adult, largely similar between pediatric and adult with a few differences. And then if we figure out we're right, we know what type of pH they have. Unfortunately, right now, there's not a ton of different medical therapies that I'll cover in a second. But the first thing we do is try and avoid anything else that's going to irritate those lungs and irritate that lung blood vessel. So if a person has trouble swallowing, that has really no direct cause of pH generally, but it can sure make pH hard to manage. It can make it worse. So if somebody is constantly swallowing poorly and irritating their lungs, as you sometimes see in a formerly premature infant, we want to handle that. So what I talk about that is sort of handling concurrent or comorbid conditions. So basically, we want to make sure there's no other thing ticking them off, making them angry. And that could be anything from the flu, COVID, you'll probably talk about later, to swallow dysfunction or other concurrent illnesses. So if we feel like we're managing that, we also make sure they're not chronically with an oxygen requirement, because having an oxygen requirement can really irritate one's lungs and make their pH worse or even cause pH. So a lot of our patients in pediatrics, even more commonly than adults, take chronic oxygen therapy to prevent dips and valleys in their oxygen level. If you get to a point where you're thinking about medical therapy and you're confident of the diagnosis, which is a slightly different question, there's really 3 large classes of therapy, and many of the people who are commenting on here probably know those 3 classes all involve relaxing the blood vessels or vasodilators. Vaso is vessel, dilate is relax. So we want to relax those blood vessels. Obviously, we'd rather be talking right now, Jill, about curative therapies. There's not really a curative therapy right now medically. But of those 3 classes, you see the big group that many of the people are on is called sildenafil, or tadalafil is the most common one in North America. That's Cialis and Viagra. So traditionally, those were sex-enhancing drugs because they relax vasculature, not just in the lungs, but also in other parts. And for males, it's in sort of the arteries of the penis. And so that they were discovered originally because they were thought to be blood pressure medicines for getting back to the old lady with high blood pressure, or the old man. But they don't work great in the body circulation, except for in the lungs, thankfully. So they relax the lung blood vessels. And so that's one big pathway. Those are kind of related to nitric oxide. Some of the people listening may have had experience with nitric oxide. Nitric oxide is not a portable outpatient experience as we know it right now. But so that would be one pathway. The second pathway would be something called the ERAs, or endothelin receptor antagonists. So this would be, you may have heard of bosentan, which is called Tracleer. You may have heard of ambrisentan, which is Letairis. There's also one called macitentan. Those are the 3 big ones in North America. And they all kind of do the same thing. They relax the blood vessels by impairing their ability to clamp down when exposed to a compound called endothelin. So they compete for the binding in the blood vessels, and so they relax the blood vessels. So that's an oral set of medicines, just like Viagra or sildenafil, which is also called Revatio, and tadalafil, which is having a brain fart on what tadalafil is. But anyway, I'll come back to being live. Sometimes you have this thing up. But so those are all oral medicines. And then there's a third class of medicines that can be taken either orally, and by oral I also mean through a G tube if a person has that. Can be taken by IV, can be inhaled or given what's called subcutaneously under the skin. And those are derivatives or itself a drug called prostacyclin, which is a powerful vasodilator, a relaxer of the blood vessels in the lung circulation. Its chemical derivative that you see more commonly now is called treprostinil. Treprostinil can be given in a number of different ways because it has a longer half-life. And then the third relative of that that you most commonly see is selexipag, which is also called Uptravi. So Remodulin is the treprostinil-derived relaxer of the blood vessels in that class, and Uptravi or Selexipag is an oral, similar but slightly different agent. So I hope that kind of gets at the sense. There's 3 different classes that we use. None of them are curative, unfortunately.
Okay, and then I just have a question from the audience.
Yeah.
What is your feeling on moving from sub-Q Remodulin to an oral like Uptravi? Or would it?
Yeah, so that's really important. And in fact, while you and I were while we were having the technical difficulties, I got paged by my colleague, Anna Brown, who's a nurse practitioner who is in our program with me. And we have to think a lot of times about whether a person is appropriate to transition them either from an oral agent like Selexipag or oral hereditary, oral Remodulin essentially, to sub-Q, or the other way. From sub-Q, maybe you can back down to oral therapy. I don't see the exact question off the top of my head, but basically the oral therapies of the class that we're talking about now, the prostacyclin, Remodulin, treprostinil class, the oral therapies are quite nice, but they have a ceiling above which they're difficult to tolerate orally, because when you take a medicine orally, they can have some local actions in the gut. And so they cause some diarrhea, they can cause some tummy upset. And so a lot of children need higher doses than we can give them through their stomach or through their intestinal tract. And so you'll see us step up to what you might think of as stronger drug delivery as sub-Q or IV. Sub-Q means subcutaneous under the skin. But there are some children who achieve a stability and can come down off of continually delivered subcutaneous or IV therapy and transition to an oral intermittent medicine. Or some children have to go the other way, have to step up to the subcutaneous or continuous delivery. And that's a very personal decision and a very family and physician provider based decision, obviously. So it's hard to generalize that too much.
Yeah, and we do appreciate, we're trying to answer questions generally here. I know people have some specific questions regarding, their children, but we do like to, try to have general questions from the audience just so we can address them and they apply to everyone. I am getting a lot of questions or discussion about genetic testing and recognizing, what are your thoughts on genetic testing for hereditary pulmonary hypertension?
Yes, that's a great question. So we get this a lot, and this is an area that adult and pediatric PH is probably a little bit different. We're much more aggressive in pediatric pulmonary hypertension care in genetic testing, truthfully, than they are in the adult world. So the first thing you should know is that genetic testing at this time does not directly impact the way we treat the child, but it has potentially profound impacts for understanding why they have the disease, and also impacts on the family for thinking about their progress through their next phase of perhaps having more children. Our patients who are children, that means they have siblings, and that also means they have parents who may be thinking about having other children, as opposed to, say, a 40-year-old person diagnosed who may be thinking about children his or herself, but they don't have quite the family unit that we think about in pediatrics, essentially. And so pretty much anyone with group 1 PAH that is thought to be familial, that is 2 or more people in the family have the disease confirmed, or we know of a genetic mutation in the family that we think causes PH in that family, or if there's congenital heart disease, we are very apt to suggest and counsel and talk to the family about the possibility of using genetic testing to determine what we would believe to be the primary underlying cause for that child to have PAH. So we have a lot of discussions with families about the pros and cons of genetic testing. The downsides in North America are relatively small. As you know, we have a PHA is working right now with Dr. Wendy Chung, Greg Elliott, yourself, and me on distributing a visually available educational 3-part series on genetics and pH. So I think you might mention that later. That's something that hopefully could be a resource to people, and I'm happy to talk to them more. But in essence, you ought to do genetic testing within the confines of talking about it. So counseling with people who understand what it's going on. So you may have a general genetic counselor, you may have a physician, you may have a nurse practitioner or other provider who understands to teach you a little bit about what this means. Thankfully, in North America, as I said, it's pretty good. There's a Genetic Information Non-Disclosure Act in Europe, in North America. I don't know as much about Europe, that protects people in North America from learning about genetic findings that may be futurely impactful to them. It has some restrictions on how protective it is in terms of future disability and life insurance acquisition. But in general, you're not going to learn that your child has a genetic disease and not have care for them moving forward, thankfully, in the United States. So we talk a lot about the benefits of genetic testing for understanding why that person may have PH. And then we will turn around and maybe talk to the family about what does this mean for you to have other children? And what does this mean for you for testing the siblings of that child or even yourself as a parent? We do a lot of healthy sibling screening in our clinic as well, because that's just something that I believe is important, because I don't want someone to present with a profound disease that they had no idea they had. But there's some center variability in that approach. There also is some genetic testing you're starting to see more commonly, and I saw some TBX4 comments on the side here too. And TBX4 is one of the causes of developmental associated lung disease that kind of spills between group 1 and group 3. And so the TBX4 spectrum disease has sort of reminded us all that genetically inherited irregularities that can cause pulmonary hypertension can be a little trickier to diagnose. And so we've begun to think more carefully about children who have early onset or profoundly different PH and whether genetic testing would be appropriate for them as well, particularly group.
So to follow up that, I have a question that is persistent pulmonary hypertension disorder hereditary?
Yeah, so persistent pulmonary hypertension of the newborn, or PPHN, you have a bunch of these on the side here, as you know. As we currently know it, no, it is not inherited, it is not heritable. But I think like everything genetic, that is apt to change in the future. It is possible that there are inherited variations that we don't currently understand that may make someone a little bit more prone to develop PPHN. And so we don't totally understand the mechanism of that. One thing that I've always thought is fascinating is that if you look at people who have idiopathic PH in their children, so diagnosed during childhood, age 3, 4, 7, 15, they are actually enriched for people who have a history of PPHN back in the day. And probably a neonatologist not inappropriately told them, you had a rough 28 days after delivery, your child got better, no problem, there'll never be another problem again. That's generally true, but there is in a minority of cases people who have then go on to develop idiopathic PH. It's so common to have PPHN and be fine thereafter that it's very dangerous to suddenly tell people you are at risk for PH in the future, because we don't know if that's true. But the reverse is true, that some people with idiopathic or heritable PAH have a history of having had PPHN. And you see that a little bit in the TBX4 population as well, by the way.
So with that being said, is there testing that people, I mean, I feel like there's a lot of questions about, should I have had testing? Could testing have been done? Can anything preventative have been known?
So I think what you're saying is, if I had a child with PPHN, should I have tested them for genetic testing? Is that right?
Yeah, and then there's other questions too about other testing in general. Do you should I have had some testing done for my child at a certain age? What testing needs to continue to be done? We have a whole slew of testing questions.
Yeah,
we can touch on a lot of it.
Really good and really hard. So I would say that PPHN, and there's a nice PPHN handout that Mary Mullen worked on with, I think, Michael Timpin at PHA. We looked at, that's a really nice brochure. But so generally, PPHN is not thought to be genetically transmitted. I don't want people to leave here thinking that. I think, like anything else, anything's possible. But if you have PPHN in a child and they get better, I would not rush to genetically test unless it's profoundly out of the normal. If someone had PPHN that was profoundly out of the normal and now the kid's 5 and they're on this call, they probably do have something a little bit different, if that's true, because you probably wouldn't be on a PHA call if you have a 5-year-old who had PPHN otherwise. Unless, if your kid's 21 days old in the unit right now with PPHN, I'm hopeful for you that this will all go away and you'll be better. But in general, genetic testing is, it's always something we should think about. You should talk to your provider about it. It's not always appropriate. We don't do it for the group 2 patients. We don't do it for all group 3 patients right now. We think about it very carefully for all of our PAH group 1 patients. The other thing to keep in mind is if you had genetic testing 4 years ago, we don't have a great mechanism as a field right now for just automatically retesting that blood. So if your child was diagnosed 5 years ago, had genetic testing that was, quote, normal, it might be worth having a discussion about whether it's time to repeat that test. Unfortunately, there is not a system by which the companies that do the genetic testing go back and look at your DNA. That is not currently happening. So it's always worth revisiting every 3 to 5 years. If you've never found anything, but you think genetics is important, at least having that rediscussion with your provider, if that makes sense.
And then I'll ask, So I know we normally use testing, diagnostic testing to diagnose. Is there any yearly testing that children need to receive then after being diagnosed?
Yeah. Again, I don't want to be too evasive and just say talk to your doctor, because that's not fair either. But there's a lot of things that many of you know we do a lot. So in our clinic, we see people about every 3 months once they're stable and things are going well. And at virtually every 3-month visit, we do a physical exam. Obviously, in the era of COVID, we've done more telehealth in the last year than we've ever done, as you and I were chatting about before. But in general, we'll see you. We'll put our hands on the child. We'll examine them. We'll do vital signs. We'll do blood pressure, of course, of just systemic blood pressure and other vital signs, check their lung oxygen saturations. We usually do, for those children who are old enough, we do yearly lung function evaluation just to make sure there's not a subtle decline in lung function, and also because there are some components of the lung function testing, including diffusion capacity, that can be helpful to measure. We get Q3-month echoes in our program. Sometimes you do every 6 months, depending on the individual, but we do a lot more frequent echocardiograms than you see in the adult population. They probably do once or twice a year, twice or 3 times a year, depending on the program. We used to do cardiac cath yearly. We don't really do that consistently anymore. We are much more flexible with, if things are going well, we may push out cardiac cath every 1 to 3 years, depending on how things are going, or sometimes even longer. It just depends. Blood work is an important component. We know that there are certain metrics. You may have your doctor talk to you about BNP or NT-proBNP as a marker of right ventricular or heart strain. It's really a generic heart strain measure. We'll get that about every 3 months in patients. And then depending on what therapeutic you're on, you may require more aggressive testing. As you all know, bocetin in particular requires monthly blood work, including pregnancy testing for people of pregnancy-associated age, and then ambricetin, which is another drug in that class, Letairis, will require every 3 months blood testing. So at a minimum, you're probably getting an echo at least twice a year. You're probably getting lung function once a year. Some centers will do cardiac MRI every few years in patients over age 7, 8, 9. And then we also will do cardiopulmonary exercise testing at intervals variably.
Okay, so I am going to switch and transition to another topic. I know we're talking a lot about treatments and medication.
Yep,
we tend to hear from a lot of parents, they're trying to make life normal for their kids. Can you speak on the ways and the activities that can be modified, or the considerations that parents can make?
I think that's so important. Thanks for mentioning that. So it's another way children and adults are different. So first of all, we're talking about children anywhere from 6 months, even 1 month, to 19 years old. And so these are active people who we want to feed, grow, develop, play, and everything else. So we tend in our clinic, and I think most clinics do this, tell people to, if you have a serious form of PAH, a serious form of pulmonary hypertension, such as PAH, or you're significantly impaired, say group 3 bronchopulmonary dysplasia PH person, we want you to get exercise. So we want you to be cardiopulmonary fit. And I tell people, Jill, that it's just like any other disease. You want to be as healthy within that disease strain as you can be. So if your 90-year-old grandma has hypertension, that doesn't mean you don't want her to be at her absolute healthiest point, because you want to be as healthy as you can be, so when the bumps in the road hit, you're ready to roll. So same thing for our children. So I want them to be active. I don't want a few things. I don't want them to push themselves to the point that they are so short of breath that they are impaired. I don't want like a coach or a PE teacher or a parent pushing them to the point that they can't titrate themselves. So children should have the ability to say, enough is enough. I can't do anymore. So I'm real nervous about them doing aerobic exercise that is pushing them beyond their means. So I like them to be able to dictate it. But I want them to play. I want them to run around and play outside with their peers. Obviously, at early times after diagnosis, there may be some slightly difference to that. But generally, stable children, regular exercise, walking, gentle jogging is usually okay. We want them to be physically fit. I don't like people, if they're willing to not do it, to scuba dive, to do things that have a lot of forceful maneuvers that require them to do what's called a Valsalva maneuver, which is a little complicated to disguise on this talk, but things like isotonic exercises. So when you're pushing against a force and straining, as I'm trying to show you right now. So things like that. Pull-ups can do that. Weightlifting in general, not that a lot of kids weightlift, but I don't like them to do weightlifting without us talking about it carefully. Similar to that, wind instruments are something we try and avoid, because it's a similar kind of concept. So if you're blowing a trumpet, like you're pushing against a resistance, and that can cause strain in your chest cavity. So we try not to do that. I'd rather them do the flute or the guitar or some other choice. They can sing, they can dance within their means. If they're going to do flying, like if you're going to take a long trip, we'd like to know about it, so we could at least talk about the options, whether they need oxygen on the plane, because planes are actually slightly lower oxygen delivery than here on ground. So those are the big things we talk about with families. And then we very much encourage other mechanisms to be careful, like flu shots. And of course, if and when COVID vaccine would be available, we would be in favor of that and other things.
So we do have a lot of questions coming in. I know that we have until a little before 4 o'clock with you, because we have, a time constraint today. Out of curiosity, I know we're talking about children and pediatrics. What is the age range when you do end pediatric care, when you transition over to another doctor?
So that's a really important topic in pediatric diseases in general, especially PH. So we're fortunate here at Vanderbilt to have a PHA accredited adult and pediatric center. We're actually not directly affiliated, but we work extremely closely together. And so sometime around graduation from high school to graduation from college, we transition most of our individuals. So if a child in our program has, is going to be going to Vanderbilt, for example, and they're on campus, they're around, they often will stay with us in the pediatric program until they feel comfortable transitioning. Because as you can imagine, there's just differences between the adult and pediatric program. We tend to handhold a little bit more. We involve parents a little bit more. You go to the adult side, they're wonderful doctors, but they're not talking to the mom and dad, they're talking to the patient. So technically, it's initiated around the time of high school graduation or age 18. In practice, it either happens at that point or at the time of college graduation or college age graduation. Certainly, if someone's graduating high school and they're going to go out and work on their own, they're going to go to into business and other things, we'll encourage them to kind of get introduced to the adult program and transition then. But there's some variabilities, and you see it a little differently also within the congenital heart programs. Sometimes they keep their patients longer, and so we do that as well for some of our congenital heart disease patients or children who have developmental impairments that make it hard for them to transition to adult programs. So we've got a good number of people who have developmentally impaired challenges that may or may not have anything to do with their pulmonary hypertension who stay with us into their early 20s.
Okay. So I am going to look over at some of these questions. I know we're going to be wrapping up shortly, but there's a few questions regarding the number of drugs approved by FDA. In Europe. I don't know if you can see it on your screen.
I saw it before. I think that was that from Anton. Let me see.
So basically the question is, the number of drugs approved by FDA in Europe for adult PH is way higher compared to the number of drugs approved for pediatric PH. Mm-hmm. Can you speak on that? If there's, knowing that you're in clinical, you're involved in clinical trials and things.
Yeah, great question. So what he's alluding to there is that in pediatric diseases broadly, in subspecialties, and particularly in pediatric PH, most of the drugs that we deliver to children in the United States are not approved by the FDA. FDA is the Federal Drug Administration charged with approving agents that we can give to kids and adults. So in the United States, Bocetin is approved for delivery of pulmonary hypertension medicine and inhaled nitric oxide in the hospital. And other than that, we're pretty much just doing it off-label. So we're using experience, we're using what we know from the adult literature. In Europe, I think sildenafil is also approved for children. It did not get approved in the United States for reasons that are complicated and probably beyond the scope of this discussion. But we routinely use medicines that are not FDA approved. We do it carefully. We're not willy-nilly about it. The thing that makes me feel a little better is you're not alone. Virtually every other rare disease of pediatrics is using medicines off-label. It doesn't mean it's perfect, but we track it carefully. We write about it. We talk about it with our colleagues across the country and around the world. And so yes, we use a lot of off-label drug. I'm not sure I'm answering what Anton said though. How can we change this situation? So he makes a good point. So adoption and appropriate clinical trials for pediatric PH are hard to do. A few reasons. Number one, thankfully PH is rare. Number two, it's hard to do drug trials in people where you don't have extremely homogeneous or similar populations. So you see these in adult world, right? Like the incidence and impact of PH relative to this children population, relative to the adult population, is fairly similar. It's just there's a whole lot less kids in the United States. Well, I think the U.S. has 300 million adults and 30 million kids or something like that. So there's just a lot less kids. So if you have the same rate of disease, you have lower numbers. And so in pediatric PH, we have lower numbers. And then on top of that, we have a lot of different subtypes. And so drug trials are hard to do in multi-subtypes. So you try and get like all the same type of disease. Well, if it's a rare disease with a small number, it's hard to get the same type of disease. So we don't have enough drug trials in children. There's several going on right now. Most of them end up being populated by international contributors. We do our best in the US to participate as well. The other thing that we have that we're benefiting from in the United States is we have great access, and in broad Europe, they have great access to drugs. But that also means that motivation to be in a trial is lower sometimes. Because if I'm going to take a patient and I'm going to say, would you be willing to be in this drug trial? That means you cannot take this drug until this trial is over. Well, that's a hard sell sometimes for families. And so sometimes we have a hard time recruiting in Europe and in North America for trials, because the options for drugs are larger, as opposed to, say, our colleagues in Asia or in Africa, where they have a less robust opportunity to access drugs sometimes. And so they tend to recruit better because that may be their only chance to get tadalafil, for example. But it's absolutely right. We need to do more. There's a comment also about sotatercept, which is looking very promising, as potentially having some impact beyond just vasodilation. There's been no pediatric trials planned in that yet. As you can understand, a drug company is going to be really careful. They want to get that drug out to market before they start risking its FDA approval on a random event in a child. So it's the same problem we have with COVID vaccines, as you can imagine.
Okay, so I'm probably going to give you 2 more questions and wrap up very quickly. There's a very straightforward question. What heart pressure number is considered severe and high risk?
That's not straightforward at all.
I like that. Very straightforward for you.
So there's a set cutoff of 20 or higher for pulmonary hypertension. Above 25 or higher is when we start treating technically, although we treat sometimes 20 to 25. There's less medicine. We use equipoise. There's less understanding of what it means severe. Severe has less to do with the pressure in my mind and more to do with how the child adapts to it and how their heart adapts to it. But you could think of maybe if you're over 75% of your pressure in your systemic circulation is also present in your lung circulation, that would be pushing severe. Certainly if you have equal blood pressure in your lungs and your body, remember I said it should be 5-fold lower in your lungs, that's pretty severe. But other metrics of severity include poor nutrition, not growing well, the heart looking more strained than it would. Some people's heart strains under lower pressure than others. So there are a lot of factors. There's not just one number to categorize you as severe or not severe. But certainly if you're getting more than 3/4 systemic, you're starting to get severe.
Okay.
What was that other question?
The other question I have for you, and more so to wrap up, because I know your time is getting very close to ending, and I do appreciate your abbreviated session with us today. We're going to try answering as many things and providing other resources for our folks. What are 3 things that you want every parent, guardian, or caregiver of a child to know?
Oh, it's a lovely question. Okay, number 1, you're a partner in the care. I always forget. You're a partner in this process. So be active, be engaged. As those of you on this call certainly are. You're part of the experience, an advocate for your child. So I would say be engaged and understand what pH is, how you can best help your child, and partner with your provider, as I know you do. And also don't forget to remind your provider that you're a partner in this. Most importantly is your child, of course. Number 2, there are therapeutic options out there. We can do this. We can relax those blood vessels. We can make children stay well for a long time and sometimes outgrow it, but we've got to treat them. The medicines are hard to take. I can't take an antibiotic for 10 days for ear infection twice a day. We're asking you guys to take 3 different classes of medicine, sometimes delivered continuously. It's hard. Hang in there. You're not alone. It feels like it sometimes, but you're not alone. Talk to us, talk to the PHA network, other things. But if you can handle those medicines, do it. There's too many things to say, only 3. But number 3, I would say is, have optimism and excitement that this field is changing so rapidly. I've been doing this since 2006, on faculty since 2008, and it has changed dramatically even the last few years. We're learning more and more. We are studying children. We're not doing it enough, but we're trying. And so have hope, have faith, hang in there. Other things is oxygen's always your friend. Don't be afraid about talking about reassessing when things are going poorly or when things are going well. Maybe it's a time to make a change in a good way or a bad way. And then, do whatever you can to stay healthy in all other respects.